good afternoon, and good evening to our speakers, chairs, and audiences of ACNS webinars in different parts of the world. We're back again with another session of ACNS webinars just for you. The speaker for the first session of today is our honored guest and senior faculty from Australia, Professor Girish Nair. Professor Girish Nair is the director of functional neurosurgery at the Royal Melbourne Hospital and head of neurosurgery at the Western Health. He underwent his basic training in Kerala and further qualified as a neurosurgeon in Australia. He subspecializes in minimally invasive spine surgery and functional neurosurgery, including deep brain stimulation and neuromodulation for pain. In addition to his clinical work, his research interests also include stem cell implantation in Parkinson's disease, use of artificial intelligence in Parkinson's disease, and modification in utilization of neuronavigation to optimize minimally invasive spine surgery. We are extremely honored to have him today as a speaker at our webinars, and today he'll be talking about DBS in Parkinsonism. The speaker for the second session of today is an honored guest from China, Professor Q Tianming. Professor Tianming is associate professor at the Department of Neurosurgery at the Huashan Hospital, Fudan University, Shanghai, China. His subspecialty of interest is pediatric and cerebrovascular neurosurgery, and he has won several awards for his excellence in academic neurosurgery. He is the author of several articles published in various peer-reviewed journals, and we are extremely honored to have him today as a speaker at our webinars, and he'll be talking about pediatric AVMs. The chair for the first session of today is a stalwart in the field of functional neurosurgery, Professor Morgan Hodai. Professor Hodai is currently an associate professor of surgery and the surgical co-director of the Joy and Toby Tunningham Gamma Knife Plate Surgery Unit at the Toronto Western Hospital, Canada. Professor Hodai is also affiliated with the Institute of Medical Sciences Faculty of Medicine as an associate member. She has pioneered and enlisted international collaboration in the application of new education tools in the field of neurosurgical education in the developing world, focusing on structured online course modules in neurosurgery. Professor Hodai also heads the famous Hodai Lab, which excels in the study of pain and has been recognized with multi-year peer-reviewed funding, including operation grants from the CIHR and Multiple Sclerosis Society. We are extremely honored and thankful to her for lending her support for us on more than one occasions and accepting this invitation to chair the session of Professor Girish Nair. On behalf of the Education Committee of the ACNS and the President, Professor Yoko Kate, I would like to welcome both the speakers and chair to this online platform of ACNS webinar. Dr. Liu Boon Singh from Malaysia is my co-host for today. And with that introduction, I would like to hand over this virtual podium to our first chair, Professor Morgan Hodai.
Thank you very much, Dr. Raja. Thank you to you and Dr. Kato for inviting me. And it really is a pleasure to be here with my Asian colleagues to attend this webinar and chair this session. Thank you for your kind introduction of Dr. Nair. I look forward to his talk. This field of work is incredibly exciting and has accelerated to a very large degree in the past 2 decades. From the very first start of the initial efforts of deep brain stimulation by Professor Benabid to now the establishment of deep brain stimulation for Parkinson's disease as essentially a standard for the management of these patients. The level of understanding of the neurophysiology of the deep circuitry of the brain that are responsible and participate in this condition, how we can modulate it, and what the different targets are in the management of Parkinsonism is a really fascinating area, and I'm very pleased to give the platform to Dr. Nair for his talk. Please go ahead. We will have his session for approximately 40 minutes, and hopefully we can take some questions after that. Dr. Nair, if you want to share your screen and go ahead.
Thank you, Professor Hodai. It's indeed an honor to have you chair this session, and I'd like to take this occasion to thank Raja and my co-speakers and your co-chair, and also Professor Kato for giving me this opportunity. And I'd like to start by paying tribute to the gentle giant, Professor Kano, whom a lot of us have been privileged to know. And he's been probably a great inspiration to neurosurgeons like myself, not only from the Asia Pacific region, but also across the world. So when we talk about Parkinson's disease, when we talk about Parkinson's disease, it can look many different ways for us. It can, at the minimum, look like what we're seeing on the right side of the screen with someone who has tremors, but then you will see someone on the left side of the screen who has almost a full complement of what we call Parkinson's, including having tremors, a bit of camptochomia, bent over, gait freeze, and quite activity limiting symptoms. So What is Parkinson's disease? Parkinson's disease is a complex syndrome which has many subset of symptoms to it. We know the common constituents, which are the akinesia, the stiffness, the tremors, but then it's a bit more than that. It goes on as the condition evolves into postural instability, disturbances in balance and gait, and also gait freeze, not to mention all the psychological and the psychiatric effects that come by the side. And these symptoms tend to become prominent once the level of dopamine drops below 60 to 70%. In Australia, the burden of disease of Parkinson's is calculated to be about 64,000 at the moment, and it is expected to grow to about 240,000 patients by 2033. It takes for about 5 to 8% of the general population in residential care. And recent estimates have actually escalated in the COVID scenario to about a diagnosis of about 27 patients per day. We know that levodopa is the medication of choice, and it does tend to provide good control in most patients for up to 5 years. The AN estimates, however, that about 10 to 20% of patients with Parkinson's disease may be eligible for DBS, but in clinical practice, do they actually eventuate into this number? That's something we'll look into. So Parkinson's disease, treatment of Parkinson's disease is not limited to just medications. And what is generally described as best medical therapy in medical literature includes not just medications, but also resources at the patient's disposal to address all the other symptoms we saw, which includes swallowing difficulties, speech difficulties, having psychological problems. And so when we talk about a patient with Parkinson's having best medical therapy, that should include all of these resources. And where I work in my state of Victoria in Australia, we unfortunately, because of the widespread of patients around the state, we have only about 3 or 4 centers that have access to all of these facilities at one point. So when Parkinson's disease progresses and it goes beyond what levodopa can take care of, it goes into the advanced level of treatment. And that then opens up a lot of options, ranging from LCIG, DBIS, apomorphine therapy, and then research prospects such as stem cell therapy and gene therapy. And as you can see, each of these has a role, but then it also comes with its own set of risks and possible complications. As Professor Hodai mentioned before, Professor Benabid was the pioneer who set along the current era of deep brain stimulation as we know it. Prior to that, there were all attempts of various lesional and other modifications of modulation techniques, which did possibly take neuromodulation in a bit of disrepute. But after Professor Benabid's work, we have an improved understanding of how DBS is useful, better understanding of the neurophysiology, and it's certainly a well-established modality of treatment in selected cases of Parkinson's, at least over the past 30 years. So what is deep brain stimulation? Well, at the minimum, it can be defined as a neuromodulatory procedure which involves placement of neuromodulatory electrodes into chosen parts of the brain, which is then connected to a pulse generator, which delivers a reversible stimulation in a controlled manner, which then allows us also to conduct blinded studies. So does it work? As I mentioned, in well-chosen patients for which there are a lot of screening criteria, it does tend to provide control over motor fluctuations, gives an on phenomenon without dyskinesia, and in most patients, on average of about 30% of reduction in medication requirements. It, of course, brings about significant improvement in the quality of life and activities of daily living. On the side, if you were to mention about essential tremors, it has been shown to provide good control of tremors in ET for up to 6 years, and also significant improvement in dystonia. So who are these patients whom we define as eligible? Well, they should be patients who respond to levodopa. They have to be patients who do not have other medical comorbidities that limit them from having surgical treatment. And they're usually patients who have good symptom control, but over time, as there is dose escalation, they start developing adverse effects such as dyskinesias, nausea, vomiting, and hypotension, etc. It is important to recognize that research and publications have shown that DBS is better than the best medical therapy in advanced PD in patients who have severe motor symptoms. And certainly a combination of DBS and best medical therapy overrides the benefits of just medical therapy. It used to be thought that DBS is sort of to be considered as one of those last resort type of treatment options. But the early STIM trial has shown that it is not really the last option, but in patients who have early motor fluctuations, they're better off considering DBS sooner rather than later. So if we have this volume of patients with Parkinson's disease, and then we also calculate that there is about a 10 to 20% of patients who are eligible for DBS, well, then why aren't we seeing that level of take-up of the procedure? And part of it is because of how the public perception is of what a deep brain stimulation involves. It is scary. The thought of someone drilling into your head and putting wires into your brain and then connecting it to a battery is certainly a scary thought. And needless to say, there is always the apprehension of having to have the surgery awake. And of course, the patient friendliness and the aesthetic value of what we provide as a surgical option. This is a true patient account of what they perceived as what surgery they have to put themselves through. And you can imagine in most of our patients whom, those of us who treat Parkinson's disease, it is usually a person who has been on a journey of Parkinson's disease, is apprehensive, is frail, is unstable, has psychological problems, and then to ask them to be still while you drill a hole into their head is certainly a big ask. But most of our brave patients have put themselves up to it purely because they see light at the end of a dark tunnel. Now, is that really necessary for a patient to put themselves through that is what we have to evaluate. So the preconditions that are established traditionally are that the patient needs to be awake, and then microelectrode recordings are mandatory. Is it really true? And why does it need to be awake? The reason for that that's given is because we have to visualize the target, and then we should have confirmation and good accuracy of placement. And this is important because earlier, the quality of imaging that we used to have did not lend itself to direct visualization of the subthalamic nucleus, which is sort of the bread and butter target for DBS. And hence all of these allied supporting information was required of the neurophysiological confirmation to proceed to the procedure. So the common targets are subthalamic nucleus and the AVM, and certainly there are a limited set of conditions where a GPI might be used, but certainly it is not one of those targets that is high on the list. Most of the time, an STN is the chosen target. And for the purpose of my talk, which I'm centering around the role of MER and the need for the awake DBS, we'll be talking mostly of the STN target. So subthalamic nucleus is a very tiny target. And as you can see, it is located right in the center of what is fairly densely populated real estate. And within the subthalamic nucleus itself, there are subdivisions, and to get the best benefit, you have to preferably get your electrode positioned in the dorsolateral part of the subthalamic nucleus. Now, when you put that information together with these type of scans, which is probably what our predecessors had when they were planning these procedures, you can quite well understand as why you needed the patient to be awake to test and why you needed all the detailed electrophysiological testing. But now we have images like this, which are not just shades of gray, but have sharp delineation, particularly because of the high concentration of iron in the areas of interest. And then this has evolved even further, excuse me, where you can see the comparison and the clarity that you get when you have to look at the subthalamic nucleus and the clear demarcation of the red nucleus. So do you really need the patient to be awake? Apparently, there is a school of thought that believes that that is still required. And the explanations for that is that you need confirmation of the accuracy and you need intraoperative confirmation that your stimulation is actually working and that it will also help optimize the clinical outcome. We have to understand that MER or microelectrode recording was a technique that was initially introduced not only because of the limitations of imaging, but when we could not see the target and you are also doing irreversible lesions, which is very different to what DBS is now. But is it really true? This is an article that is from a while ago, and that compared the MER target and as to whether that correlated completely with where you would place the electrode based on your macro stimulation. And this is from Richard Sherman's group. And what it concluded was the activity where you got the best MER did not necessarily correlate with the location that gave you your best clinical response. This is also another paper that came from Jans Walkman's group, which actually showed us that you're probably better off focusing on good anatomical targeting based on clear and clear sort of chosen scans that are available on the T2 imaging and some modified sequences that are now available, rather than, and depending on anatomical targeting rather than on the electrophysiology. This is a more recent paper from Casey Halpern's group, which compared the awake versus asleep in a comparison and a meta-analysis and give us two good pieces of information. One, that the motor outcomes of awake DBS was comparable to asleep DBS, but also that the number of passes that you made when you do an awake DBS does increase the risk of complications, specifically with regards to cognitive changes as well as intracerebral hemorrhages. Apologies if this is not projecting properly, but you can see on this table that there is a significant difference when you look at the awake versus asleep in terms of the number of passes of electrodes, the incidence of intracerebral bleeds, the incidence of infection, and of course, the time taken to surgery does not reach the levels of significance. This is also an important factor because you have to imagine the challenge a patient faces lying still, clamped to a frame while the whole operation is happening. MER is also expensive. It has been calculated that the cost of a deep brain stimulation can blow to almost double when you use microelectrode recording. So you really have to think as to whether you really want to keep doing that, something that might not be absolutely necessary in this day and age, except for, as some of our colleagues like Dr. Haris in the United Kingdom say, that it should probably be reserved for research purposes rather than clinical indications. This was a very important paper. We keep talking about the role of microelectrode recording and how the patient has to be awake and how that is going to get us to the sweet spot and deliver the best outcome to the patient. But does it really happen? Well, this looked at 28,000 DBS procedures, of which 87% were done with microelectrode recordings, and yet a 15 to 34% electrode revision rate. So does this all really add up to justify a procedure that probably does not translate to the benefits that we were hoping for? So it does seem that the anatomical accuracy is probably paramount. And historically, the translational error would be quoted around 2 to 3 millimeters. But in current literature, the accepted error would be around 1 to 2 millimeters. And even when you're using framed or the frameless technique, and when you're using an intraoperative MRI, the percentage or the error is quoted to be less than 1 millimeter. In our experience, has been about 0.8. So there are various ways of doing this. And on the right side of your screen, you have the traditional CRW frame and then the Lexel frame. And here you have the next frame, and that is the StarFix. So that's the framed versus frameless options currently available. And as we saw on the last slide, you can have the same levels of accuracy on both. This paper looked at, when we talk about accuracy of placement, you also have to compare the various techniques. And as you can see, at each step of a DBS procedure, there is always a possibility of error. And that goes all the way to your final lead fixation system. And certainly it is clear to understand that when you have less steps involved, your margin of possible error is also reduced. There are various other things that DBS surgeons are conscious about, including positioning of the patient, being a bit OCD on trying to minimize CSF egress, and also trying to minimize the duration of surgery, all of which we believe will try and reduce the brain shift. So to increase the anatomical accuracy, one of the modalities that is now available, and this is a paper from Roy Buckey's group, where they've shown that despite you finding an MER location and then choosing a sort of a macroelectrode stimulation-based location, where the lead finally ends up still seems to be a bit away from your chosen spot. And hence, having a modern resource or a modern imaging modality such as an intraop scanner is sort of quite valuable, because there you can confirm your anatomical accuracy of placement, which we have seen has an implication on your outcome. There are more and more publications coming out talking about accuracy, and this is a publication that is sort of fairly recent, which has shown that the frameless approach is certainly an acceptable way of doing it. And we also have higher levels of accuracy, but the benefits also being saving on operating time and improvement in patient acceptability and comfort. This is some of the earlier papers where, again, accuracy was certainly quite satisfactory. And this was one of the earlier papers which started commenting not only about accuracy, but also about outcomes, and end by the comment saying that further long-term evaluation is required to make sure that the improvements that we see are robust and long-term. Again, this is from Kim Burchill's group, where they compared motor outcomes of patients at 6 months in about 30 participants. And interestingly, their outcome pointed out that the motor outcomes were certainly comparable, but in the asleep group, there was improvement in terms of speech fluency and quality of life, which is more than the awake group. This paper sort of, to some level, answers the question about medium to long-term outcome. So this is a publication from looking at outcomes at 1 and 3 years. And certainly it stands the test of time, not only in terms of clinical outcome, but also in the ability to reduce the need for ongoing medication. So this was all the background. So initially, like most of us, when I started doing this procedure about 10, 11 years ago, our practice was also centered around using the CRW frame and also doing it awake with MER and macro stimulation. But then we sort of kept an eye on what was happening around the world. And, you know, when we go to a lot of these meetings, I was sort of quite charmed by what the asleep and frameless approach could offer. And what prompted me to take the leap was one of our first patients, a gentleman whom you saw stumbling along when he walks. He's actually a doctor and knew that he would benefit from a DBS, but refused to have it because he could not come to terms with the thought of having to lie awake with his head fixed in a frame, and also to have the whole operation awake. So he sort of encouraged me to take this path. In our practice, it is a multidisciplinary decision making, which is the practice in most centers around the world, involving a neurosurgeon, psychiatrist, and a neuropsychologist. And we have also a multidisciplinary team before any patient is taken forwards towards the path of deep brain stimulation. As part of a workup, and this is sort of some of the work that we are looking at publishing in the near future, we also regularly use the Parkinson's kinesiogram, which is a watch that a patient wears for about a week. And it provides us not just a subjective, but also objective measurable outcomes, because it gives us pre-op parameters of dyskinesias, bradykinesias, tremor, amount of time when there was reduced activity and everything. And then we get the patients to have these tests at 6 months and 1 year after the deep brain stimulation procedure to get more measurements. And that certainly has been something that we have found very useful. So as mentioned before, we have a multidisciplinary patient assessment. And with DBS, what we found is many a times patients are desperate, but the outcome of DBS is also dependent on patient selection and also setting expectations right. It is important to realize that DBS cannot and will not deliver an outcome that is going to be better than their best dopamine response. And it is also important to let your patients know that DBS is not a cure for Parkinson's. DBS is a treatment for control of symptoms of Parkinson's with the aim of improving quality of life. Once we all are in agreement that we have chosen the right patient, then we rule out surgical contraindications and then proceed to having a preoperative MRI and planning. Standard surgical steps. So in the initial, we are now accounting for the significant dip we had in case volumes over the last 2 years, we have touched about 57 patients of frameless DBS, of which about 44 are for Parkinson's disease. In the initial part, when we were sort of taking our tentative steps into the domain of asleep DBS, we used to still do MERs and macro stimulation, and the purpose of which would be to give us some indication as to we were in the right spot. But the macro stim was more about thresholding to give the neurologist a width of what the stimulation parameters could be, and also to pick up on whether patients were getting any early side effects. So this is how we do it now. Earlier, we used to do it with our patient using the CRW frame. We now use the StarFix system. And I personally have found it very beneficial for a few reasons. One, we are able to do both sides simultaneously, and that then tends to reduce our operating time by about 70 to 80 minutes. And then, of course, there is less amount of CSF egress happening. But most importantly, when we previously have tried to do intraoperative CTs with the framed system, the amount of artifact that we used to get would render the information we get pretty useless. But now with this frameless system, because there is not much metal in there, the quality of images is quite fantastic. We also use the MER in the earlier period, and we used to sort of depend on this type of listen. And then we used to go on to doing macro stimulation, but in the latter half of a cohort, that's something that we have given away. And in our current workflow is such that we place the leads in, and we have an intraop CT where we straight away do the scans and then have the image fusion done to make sure that the leads have ended up where we intended them to go. This is the image fusion that we perform within theater. And once we are happy with the accuracy, we close up and finish up. Average operating time previously used to be around 4.5 to 5 hours. And certainly the other aspect of benefit that we have seen, not only about cutting down operating time, but in some of our more advanced patients, we have seen a trend towards a reduction in the number of patients who stay for long within the hospital, but also go on to requiring post-op rehabilitation. And we believe that this is a reflection of the reduction in the operating time. So this is the patient we saw before, my first patient of the asleep frameless DBS, and this is him at about 3 months post-op. He is now 4.5 years down after surgery and still continues to maintain his benefits, and is actually one of our mascots for our program, and has volunteered himself to teaching. So with that, I'll conclude my talk. And this is our hospital at the Royal Melbourne, and I'd be keen for all of you to tap on us if and when you guys borders open up, and if you're ever visiting Melbourne. And for those of you who are really interested in this subspecialty, which is quite fascinating, and like Professor Hodai said, is growing by leaps and bounds, I would encourage you to look up this site, which has this is by Patrick, who's put this together, and there's a lot of useful information and resources for those of you who are interested. Thank you very much.
Thank you very much for this wonderful talk and the advances that you've made. I congratulate you on establishing this program. Can I invite some questions from the audience? And maybe I will start with one question myself. With the routine that you set up right now, how many cases are you able to do in an average week compared to sites where there is awake surgery and microelectrode recordings?
So in our practice earlier in our hospital system, we were able to do only 1 DBS case a day. Because the logistics of we didn't have the ability to transfer a patient and do the CT within theater. So it would be going through putting on the frame, transferring the patient, going down, coming back up, and all of that. And in the hospital that I work, we are very strongly regulated by when our finish time is. So from that, this has changed. So we are able to do 2 cases a day now. Mm-hmm. And that averages out to about, depending on the operating day, our case volume, when we look at the last, excluding the last 2 years, has probably been double.
Yeah, definitely there is something to be said about the practicalities of doing one procedure. As you know, Toronto has been notoriously famous for doing awake surgery and microelectrode recording. So the whole gamut of information that we draw from assessment of these patients, both at the clinical level as well as the cellular level. Having said that, I think it is, in my view, important to note that things cannot just be done in one way. And we have observed that as well. There is, in fact, a significant proportion of patients that have great difficulty with awake surgery. And there are times in which awake surgery actually saves us from a potentially inaccurate target. So I think as the experience worldwide moves ahead, we notice that broadening our approach into many different ways of doing deep brain stimulation surgery and introducing also lesioning surgery is really important.
So I should probably make a mention that we have sort of moved into this awake frameless thing, but like you rightly mentioned, a lot of these Parkinson's patients have unfortunately level of changes in their brain, which sometimes make it quite challenging to actually visualize the STN sometimes. And in those instances where we feel that the quality of imaging that we have does not render it to direct visualization, we do fall back on the awake. So we haven't given it away, but if you're happy with the quality of imaging, then we go ahead with the asleep. But when the imaging is borderline, we still do it awake.
So that means that you perform the imaging beforehand so that you are prepared for the day of surgery. Is that the case?
Correct. Yeah, our workflow is that the imaging is done 4 to 6 weeks in advance.
4 to 6 weeks, okay.
Yeah.
Can I invite some more questions from the audience?
Sure, we can ask the audiences. There's my co-host, Dr. Libun Singh. Any comments or questions from your side?
Thank you, Raja. Thank you, Professor Nair, for a very nice presentation. Professor, I have a few questions for you, Prof. Regarding young patient who are with early young age of Parkinsonism, and we know that L-DOPA usually stop working well after 10 years of medication. So which would you advocate, whether early surgery or you wait for 10 years? My second question, Professor, you're talking about the cause of a DBS due to MER. And in your opinion, especially in low and middle income country, would lesioning a better option or DBS without MER? My last question, Professor, do you see that because of the introduction of a cannula and MER causing lesioning effect where may not be seen after follow-up in a patient with DBS? Thank you, Professor.
So with the young patient, I mean, I think the early STIM trial, what that showed us is, and I don't know how it is in different countries, but in Australia, we're still battling to get that message out. Unfortunately, you know, Australia is a huge country and the patients are sort of spread far and wide. And our system is such that the patients come referred to us, majority of them directly from their primary family doctors. And among the family doctor community, which it is still thought to be, Parkinson's is one of those things that gradually gets worse with time. And if everything else fails, then you look at DBS. So we have been trying to get the message out, and we sort of have been doing education and things like that to put across the message that certainly in younger patients who initially respond to dopamine, and continue to respond to dopamine, but still having a lot of motor fluctuations or rapidly escalation of dosage requirements leading to dyskinesias, are certainly better off having the DBS early, at least in the productive years of their life, because it also helps you put down in a majority of patients to between 30 to 50% dosage reduction of medications, which I think is useful. With regards to, sorry, what was your second one?
The option for low middle income country between lesioning, DBS without MER, or the full DBS with MER. Which one is the best option for low middle income country?
Well, I guess both are very different modalities of treatment. I mean, you know, when you talk about lesioning, are you talking about the MR guided ultrasound type therapy, or because that's not cheap therapy either?
No, the traditional ablation therapy. I mean, it's not stimulation.
So with traditional ablation therapy, I guess you want sort of, because it is irreversible, I guess you want every modality of confirmation before you do that. You know, with DBS, I mean, if you sort of have the volume of experience, you've got good quality of imaging, and if you're doing it for the indications that we've still discussed, in our practice, at least with the experience we've gathered over time, we're comfortable doing without MER.
Right. Thank you very much. One question that I would like to put across Professor Krishna is that with the advent of 70 MRIs, although there are limited studies regarding safety of 70 MRIs, how is it going to change the future of DBS?
So there is a lot of chatter about the benefit and clarity of 70 MRI, but really, if you look at the 3 Tesla, there is good level of clarity of imaging, just it is very well usable. And with 70 MRI, we don't have it available to use for therapy, but we have a university research facility where we have a 70 MR, and we have sort of looked at that. But as of now, at least in our hands, the amount of sort of artifact that's coming through is probably a bit too much. And there are sort of actually publications now which are showing techniques where you can have your 3 Tesla MR and you can use it on a 7 Tesla Atlas to use targeting. I don't have any experience with that. I don't know if Professor Hodai has a comment about that.
We don't have any experience with that either. As you well know, Dr. Nair, part of the problem with 7 Tesla, and that used to be a problem with 3 Tesla as well, is anatomical accuracy. So maybe things are better distinguished at a nuclear and subnuclear level, but that doesn't necessarily mean that there's adequate spatial accuracy for us to use that for the purposes of targeting. There would be the need of really well done studies on co-registration and so on. So we have stopped there, and we have obviously don't have a 7 Tesla at our hospital to be able to work with that yet.
Thank you.
Right. Thank you very much. I think we had a very wonderful session, and may I invite Professor Morgan Hodai to say her concluding remarks, and we can move on to the second session. Professor Hodai.
Thank you so much. I hope that this morning's seminar has brought to you the breadth of what can be done, both in the implementation of a program that focuses on deep brain stimulation for Parkinson's disease and the advances that are being made, and the questions that are being asked perhaps again and again, and they need to be asked. How can we make surgery more efficient? What is necessary and what is not? And how can we bring better care to our patients? From my perspective, I think every site needs to ask these questions, and there are practical aspects of every site, such as Dr. Nair mentioned as well, that need to be taken into account. And eventually, every site really formulates a pipeline of the journey of the patients that needs to be as optimal as possible. In some sites that includes awake surgery, in some sites that includes a sleep surgery. Both are important, both are valuable, and I look forward to the opportunity of speaking about all of these options with our colleagues. So again, thank you so much, Dr. Nair, for your talk, and Dr. Raja, thank you so much for inviting me to moderate.
Thank you very much, both the speaker and chair, Professor Girish Nair and Professor Hodai. It was a wonderful session. So we'll move on to our second speaker, Professor Tianming Q, to hear the second session of pediatric AVMs. Yes, Professor.
Okay, thank you very much. Let me share my screen. Okay, thank you, Professor Raja and Professor Liu and Professor Hodai and Professor Nair. And it's my great honor to be here to share our small experience about the pediatric AVMs. In China, I know that almost around the world, there are 2 models of the pediatric neurosurgeons. Part of them working in the comprehensive hospitals, and they are working for the pediatric patients. And the second model is that they are working in the children's hospital, especially for children, but they have no special neurosurgical departments or such kind of departments special for the vascular diseases. So nowadays, more and more institutes or hospitals, they are managing this kind of situation, and more and more special pediatric neurosurgeons, they are working for the vascular diseases for children. So today I will review the papers and also to give some our experience about pediatric AVMs. I will have my talk on this outline. The first is the anatomy and the pathophysiology of AVM. And also I will talk about epidemiology and the risk of AVM. And also the clinical presentations is also very important, because when you meet such kind of patient, we should diagnose this AVM, and also how to evaluate AVM, and how to give the patient special and a unique treatment for this patient. And how about the outcome after your treatment? And our neurosurgeons are more focused on the surgery. So also I will talk about the surgical technique today. And at last, I will have a conclusion. First, the anatomy and the pathophysiology. Is there any different from adult AVM? In children, the intracranial vascular abnormalities have 3 parts. The first is the vascular malformations, and the second is the structural arteriopsis, and the third is the incidental developmental anomalies of the vasculature. The vascular malformation includes three different kind of situations. The first is AVM. The second is arteriovenous fistula, that is AVF. And the third one is cavernous malformation. And the structural arteriopathy includes two parts. The first is aneurysm, and the second is moyamoya disease. So today we will focus on the AVMs. You know, the AVM always consists of direct arterial to venous connections without intervening capillaries. It forms a high flow, low resistance shunt between the arterial and the venous system. And within the confines of the lesion, there is no functional neural tissue. And the AVM nidus can change over time and is prone to rupture with progressive weakening. On the right side, there is a figure. It is a model by our previous professor in our hospital. We can see that this is the model of the AVM. It consists of direct arterial to the venous connection. And the AVMs have the capacity to grow, particularly in children. You know, in adult patients, sometimes we will just follow up for those high risk and high grade AVM. We will follow up them, but maybe 3 or 5 years later, we will find that the AVM is stable. But for children, it is different. Usually, you will find that the AVM in children will grow, likely through a combination of hemodynamic changes and also the vascular genesis. Maybe that the two reasons for this kind of difference. The hemodynamic changes include the mechanical stretch and also the enlargement of the vessels, because the children, they are growing, and also developing new vessels in response to the elaboration of vascular growth factors. That is the factor of vascular genesis. And the presence of an AVM in the eloquent area of the brain may be associated with migration of the function to adjoining cortex or to be the homologue of the contralateral hemisphere. For this kind of situation, we can give the patient to scan the fMRI. The functional fMRI will detect this kind of migration. Maybe we can call it plasticity of the brain function. If the AVM results in the migration of the functional area, we can more aggressive for the treatment of the AVM, because the functional of the brain around AVM, it migrates to some other places. The intracerebral AVM usually is an isolated lesion, but sometimes it's different. We can also find a very rare situation that one patient had multiple AVMs. Although it was a rare situation, but there are two conditions for this kind of multiple AVM. One is Wyburn-Mason syndrome. At that time, it was characterized by the ipsilateral retinal or optic pathway cerebral AVMs with the cutaneous capillary malformations. This is one condition. And the other condition is HHT. It is also a dominant disorder with telangiectasia of the skin in association with the AVM. At that time, the AVM may be located in some deep structures, including the lungs and also the CNS. So for this kind of situation, we should detect more, give the patient more examination to check whether the patient suffer from these two conditions. And sometimes we also will find that the aneurysm at the same time when we diagnose AVM. It was also found in conjunction with many AVMs. In approximately 7 to 25% of cases of cerebral AVM, there is an associated arterial aneurysm on a feeding pedicle. The prevailing hypothesis is that these aneurysms are flow-related and are most commonly seen in high-flow lesions. The figure shows here is from the AJM journal. We can find that on the feeding artery, there is an aneurysm. It is very common in our clinical experience. It is also depends on the size of the AVM, and also it will influence our treatment for this kind of situation. Secondly, I will talk about the epidemiology and the risk of AVM. You know, ICH comprises approximately about half of the pediatric stroke. This ICH is non-traumatic, spontaneous ICH. These structural lesions in up to approximately 75% of these cases. AVM was the most common one, and about 10% of the hemorrhage remaining idiopathic. So when you met spontaneous intracranial hemorrhage, we should consider AVM maybe is the diagnosis. So CTA or MRA should be scheduled for this kind of patient. AVM is the most common symptomatic high flow intracranial vascular abnormalities in adults and also in children. Both in adults and the children, AVM is the most common one. But the overall frequency of detection for AVM is a little bit high. You know, there is one study, they have the autopsy about 46 cases among 3,200 brain tumor cases. They found 1%, more than 1% of the cases had AVM in their brain. So looking only at those lesions detected because of the symptoms, the annual incidence was reported as only 1.1 in 100,000 cases. So the incidence of hemorrhage for AVM is not very high. Children comprise 12 to 18 of the AVMs from major centers. And also pediatric AVMs have equal male and female distribution. They have an average presentation at 11-year-old. How about the clinical presentation? Intracranial and SAH from a vessel in the malformation or from a coexistent arterial aneurysm is the most common symptoms. And also we can find some patients will have, they suffer from the cerebral ischemia because the diversion of blood to the AVM from the normal cerebral circulation. We call it STIL, secondary to the stagnation, causing increased venous pressure secondary to the AVM. And also sometimes the patient will have the obstructive or communicating hydrocephalus due to the AVM hemorrhage. Children with AVM are more likely to present with intracranial hemorrhage than adults. About 80% of the patient of the pediatric cases, they will have the hemorrhage, much more than the adults. For children known to have an AVM, the annual rate of the hemorrhage has been estimated about 2 to 4%. Rebleeding rates is 6% within the first 6 months. This is a little bit similar to the adult AVM patients. Hemodiuretic events from an AVM in childhood, it will result in about 25% mortality rate. It is also a little bit high than the adult cases. There are several common symptomatic AVM presenting hemorrhage and also headache without bleeding. About 20% of the patient had headache, but they without bleeding. And also some patients will have seizures without bleeding. More recent data have shown that the size is not the major determination in the risk of hemorrhage. So that means not the larger AVM had more incidence of hemorrhage. And a spontaneous ICH in the children should raise concerns for the presence of AVM and the tumor. So if the patient had ICH, we should perform the MRI and the CTA or MRA for this kind of patient. But in the emergency situation, the CTA or MRA or MRI may have false negative result. We should follow up about 1 month later to recheck the MRI or CTA or MRA for this kind of situation. Now, I will talk about the diagnostic evaluation. The evaluation of a patient with an AVM includes history and the neurologic and the physical examination, and also radio studies to define the anatomy of the lesion. And also the CTA, MRA can be a means of identifying the presence of an AVM. So for chronic ischemia changes, for still phenomenon or venous hypertension, we should also give the patient T2 or flare sequencing for this kind of patient. So MRI has a better strategy to localize the abnormal structures for AVM. Until now, the DSA is still the gold standard of imaging in AVM. The DSA can establish the nature and the extent of the lesion to its blood supply and its venous drainage. And also it includes bilateral injection of both the internal and external carotid arteries and the vertebral arteries to visualize all the vessels supplying the AVM. So when we perform the DSA for AVM case, we should perform all the 6 vessels for the patient. And also after the angiography, 3D angiography with computed generated reconstruction is increasingly employed to depict the lesional anatomy. So it is very important to reconstruct the 3D image for this kind of lesion. We should evaluate the high flow versus low flow lesions, and also to see the outflow stenosis, and also vasculitis in subarachnoid or ventricular spaces, and also the number and the location of feeding vessels. All the information are very important for us to decide the treatment strategy for AVM cases. So treatment and outcome, we should focus on the such kind of information. The rebleeding rates are low in the immediate post-hemorrhage period. Different studies had different results, approximately about 3 to 6% per year. And the pediatric AVMs have a far more aggressive natural history than the adult AVMs. That means that we should give the pediatric cases more aggressive treatment in this population whenever possible. There are 4 kinds of options we could choose to treat this kind of patients. We could perform the open surgery to reset the AVM nidus, and the second, we can choose radiation, and also the embolization is another option. If we meet very complicated or high-risk AVM cases, we can also choose the observation and follow-up. So when we meet complicated or complex patients, we'd better to work together to determine the best strategy for the particular patient. So the treatment and the outcomes for surgical resection, we should choose which kind of patient to perform the AVM nidus resection. We should consider these several factors. The first is that whether the AVM located in the eloquent area, including the speech area or multifunctional area or sensation or visual area. And the second, we should focus on the pattern of venous draining. It is deep draining or it's superficial draining. And also the size of the nidus, and whether the AVM had associated aneurysms, it is ruptured or not, and whether the patient had clinical deterioration and whether the nidus is diffuse or not, and the risk of complication from other modalities of therapy, such as radiation injury to the developing brain. So if a lesion is surgically accessible with minimal morbidity, it is reasonable to consider resection, given expected lifespan of children and the morbidity of hemorrhage, because child has a longer lifespan than adult. So we should consider more aggressive treatment for for pediatric AVM patients. This is the table of the Spetzler-Martin supplementary scale system. There are 6 factors. One is AVM size. The second is deep venous drainage, and it is adequate area or not, and the age of the patient, and it is ruptured or not, and it also he considered whether it is a diffuse AVM. That's the key point of this scale. For pediatric patients, the grade 1 to 3 Spetzler-Martin AVMs treated by a resection. For this low-grade AVM, good recovery was achieved in about 90% and has a very low rate of mortality. And the radiographic obliteration rates is also very high, about 90%. These data strongly support the resection as a primary treatment for low-grade AVM. And also the radiosurgery offers cure rates of up to 90% in lesions smaller than 3 centimeters in size. So for this tiny lesion, we can also choose the radiosurgery for very tiny or small AVM nidus. This approach is beneficial for surgically inaccessible lesions. For example, it is very deep-sided in the basal ganglia or thalamus. For this kind of situation, if you find it is very difficult to access the lesion, you can choose the radiosurgery. And also the radiosurgery for pediatric patient, this strategy has shortcomings. For example, it has a delay up to 3 years for lesion obliteration and exposed to the radiation in children. That's 2 shortcomings. You know, the radiosurgery will have the effect about 3 years later. So within the 3 years, before the obliteration of the AVM nidus, the patient had the incidence of hemorrhage. So they have the hemorrhage risk before the obliteration of the lesion. And the second is the children, they are growing, they are exposed to the radiation. So that's 2 shortcomings for this kind of strategy. And also it has increased risk in younger population. And so we should choose very proper cases for radiation. For example, it is deep-seated lesions and it is inaccessible AVM nidus. At that time, the radiation is the best candidate for radiosurgery. There is one study included 40 patients and confirmed the radiographic ablation of the AVM nidus in about 35% of the patients. So these rates of obliteration, which are normally lower than those reported in the adult population. So in another word, for pediatric patients, we should know that the radiation is not the prior strategy for the AVM cases. So we should choose very deliberately, because the obliteration rate is a little bit lower than the adult population. So this is another study. They find that for the smaller AVM, for example, less than 3 milliliter or 3 to 10 millimeter, the obliteration rates of the radiation about 80% and 64% respectively. So for embolization, it is also another strategy for treatment of AVM. Nowadays, more and more literatures focus on the use of newer embolization agents, for example, onyx. However, the situation in children is more complex. The embolization using onyx is rarely used as a standard alone modality. Usually, we will use the embolization before the open surgery. We perform the embolization to reduce the blood supply during the AVM resection, but usually we will not use the onyx as the single strategy for AVM treatment. Regardless, the embolization is a significant aid in the treatment of AVMs. Just now I said that it can reduce the blood supply. And also, it occluding areas at risk of hemorrhage, such as aneurysm. For example, when you met the AVM-related aneurysm, when you resect the AVM nidus, but the aneurysm is very difficult to expose. At that time, you can use the embolization to embolize the aneurysm during your surgery. If you have hybrid operation room, you can perform the nidus resection and also the aneurysm embolization at one-stage surgery. Last year, this is another meta-analysis. They choose about 24 papers to poll about more than 2,000 pediatric patients with brain AVM. The mean age of the pediatric patients about 12-year-old, and about 64 patients suffer from the hemorrhage. And they choose different ways to treat the AVM, including the surgery alone, embolization alone, radiosurgery alone, and also combine the different strategy of these treatments. They have different results after the different strategies. They concluded that the obliteration rate totally about 70%, recurrence rate about 2.2%, and the mortality about 2.4%. The complication rate was 20.5% after surgery. The complication and the mortality rates were reduced for multimodal treatments. So they found that the multimodal treatments can reduce the complication and the mortality of AVM treatment. And for those patients treated with observation only, the complication and the mortality rates are a little bit high. That means when you treat the pediatric patients, we should we should not easy to let the patient follow up, because if you just follow up the patient, maybe the patient will suffer from complication or mortality. So this is a little bit different from adult AVM cases. Last year, the Stroke also published one paper. They have this kind of result. The 5-year recurrence rate for children, they choose the children less than 18-year-old. All the patients had initial presentation of hemorrhage. The recurrence, 5-year recurrence of these patients was about 21% after resection of the AVM. They followed up DSA for all the cases. All the DSA confirmed the total resection of the AVM nidus. Still, they have more than 20% of the cases had recurrence. That means there is a high rate of recurrence of apparently cured brain AVMs in children who initially present with AVM eruption. So for those patients, for pediatric patients with AVM, if they presented with hemorrhage, we should follow up a long time after AVM resection. Even when 5 years later after AVM resection, we should still follow up them. So this result is very important. So it also reminds us we should follow up pediatric AVM patients for more than 5 years. For our neurosurgeons, we perform the AVM resection. So I think surgical technique is very important for us. So I will have a brief talk on the surgical technique. The Michael Lawton, he said that the prevailing metaphor in 7 aneurysms, just like ballet. Aneurysm surgery is a dance that can be practiced and performed just like an elegant art. But in contrast, the prevailing metaphor in 7 AVMs, it is different. It is with some misgiving war, just like a war. So resecting AVM is just like a war. So it is more difficult than the aneurysm clipping. The tenets established 8 steps for AVM resection. It is followed by step 1 to step 8, including exposure and the subarachnoid dissection, and defining the draining vein, and defining the feeding arteries, and the pyro dissection, and then also the parenchymal dissection, and the antemomal or deep dissection, and finally resection of the nidus. There are several surgical posts. The first thing is very important is gravity retraction. Gravity retraction opens the anatomic planes for surgical access through a combination of patient and the head position. We can release the CSF and also extensively subarachnoid dissection. So the head of the position is very important to give the gravity resection. And the second one is the draining vein must be preserved until the very end of the resection. So this is also the last thing to cut the draining vein. It is also the last step. And during the nidus resection, we should avoid entering the body of the nidus. If you enter the body of the nidus, you will meet very severe hemorrhage. And also, after AVM resection, we should carefully examine the cavity, because if you have residue of the nidus in the cavity, it will result in the postoperative hemorrhage. So after resection of the AVM nidus, we should examine the cavity very, very carefully. So at that time, if you have the chance to use hybrid OR, if possible, it is very useful. Later, I will show you some case that the hybrid surgery help us to find the residue of the nidus. Now, I would like to show some cases in our team. This is a 9-year-old boy. The patient had sudden gasp once 2 months ago. The muscle strength before the operation are normal, without some special things. This is the CT scan before the operation, and this is the CTA review the malformation in the left frontal lobe. And this is the MRI showing the lesion. And this is the contrast MRI. And this is the preoperative DSA showing the nidus. Just locating very close to the motor area. And the drainage vein is on the posterior part of the nidus. Other vessels were normal. So because the lesion is deep-sided, so we also perform the DTI and also the fiber tracking showing the pyramidal checks. It is very close and posteriorly to the nidus. So this is a medial frontal type AVM. The SM grade is grade 3. This is the position for this case. We rotate the patient's head about 80 degrees. We use the gravity to retract the frontal lobe, so we can have a very clear space to let us get into the interhemisphere space, and we can control the ACA that is supplying the nidus. So this is the gravity retraction. And for this approach, we can avoid damaging the pyramidal checks that is posterior and lateral to the nidus. So it is very important to have a good position of the head of the patient to have the nidus resection. And this is post-operative CT and showing that the muscle strength of the patient is normal. And this is the post-operative MRA showing the nidus were totally resected. The patient has a very good outcome. The second case is another boy, 11-year-old. He had a progress headache in the past 20 days. The MRI showing the lesion at left parietal and occipital lobe. And this is T2 image on the sagittal view. And the MRA showed the nidus. We performed the DSA showing that the nidus supply from the ACA, the MCA on the left side. And this is the left side lateral view, and also some part from left ECA, and also left PCA also supply the nidus. And this is right side ICA and right side VA. So this AVM is left lateral, parietal, and occipital AVM. Special Martin grade is grade 4, and supplementary grading system, it is a grade 7 AVM, feeding artery from left MCA, left PCA, and MA branch. The draining into the sagittal sinus. So we perform the surgical plan for this case. The first stage is the embolization, and then the AVM resection and the navigation. So this is the embolization. We embolize the nidus via left PCA. The right side image is post-embolized image. We just partially embolize the nidus to reduce the supply of the nidus. And this is a lateral view. Only 1 day later, we performed the AVM resection in hybrid OR. In the operation, we find the blood supply is very abundant. We cut the feeding artery and then perform the nidus resection. Under the microscope, we found that all the nidus were resected. And also we performed the hematogenesis very clear. And I checked the cavity of the nidus very carefully. I think that I have resected the whole nidus. But in our routine work for this diffused AVM, we routinely perform the intraoperative DSA. We find a very tiny nidus deeply into the cavity. It is supplied from the left ICA. So we open the cavity and perform the residue nidus resection. In the first DSA, only the left ICA angiography showing the residue. Other vessels were normal. This is ECA. and this is select VA, showing that the nidus from the left PCA and the MLA were resected, but residue some nidus supplied from the left ICA. So we performed a further resection. We found the residue of the nidus and resected. It is very deep-sighted. After the residue nidus resection, we performed the second intraoperative DSA. The DSA confirmed the totally resection of the nidus. You can see on the right side, the residue nidus was further resected. So the whole nidus was achieved the totally resection. And during the operation, we performed the SSEP and also MEP to confirm the motor pathway was protected well. This is a post-operative CT scan, and this boy was, the muscle strength of the boy were normal. He recovered very good and discharged about 1 week after AVM resection. I still followed up this boy and performed another MRA about 3 months later. And just like what I said just now, I will follow this patient for another 5 years to check whether the nidus will recur or not. So let me have a conclusion. The pediatric AVMs have a far more aggressive natural history than the adult AVMs. So it supports the stance of aggressive treatment in this population when possible. The obliteration of the AVM is always the goal when starting the treatment. When we start treatment of one AVM, our goal is to totally obliterate of the AVM. If the AVM is not obliterated, it means it has an incidence of hemorrhage. So obliteration of AVM is always the goal. Surgery is considered the primary treatment because usually for the specimen Martin grade, low-grade lesions, so the surgery is always the primary treatment. If surgery is not feasible, for example, it is very deep-sighted, or the patient cannot tolerate the general anesthesia to some severe medical conditions, radiation therapy is also another excellent treatment, particularly in some smaller lesions, usually for these lesions less than 3 millimeters. High-grade AVMs may require multimodality treatment, combining the embolization with surgery or some other interventions, including radiosurgery. Sometimes radiosurgery can reduce the grade of the AVM. For example, from grade 5 to grade 4 and then to grade 3. At that time, we have the opportunity to resect the nidus of the AVM. Surgery of AVM for each case is unique and needs carefully preparation. We should read the DSA image very carefully before each case because each nidus is different from another one, especially for the pediatric case. And also during the follow-up, the nidus, the AVM nidus may grow for example, for the pediatric cases. So we should check DSA right before the AVM treatment because the AVM may be changed. Future multi-center studies and the basic research are required to have more information for this kind of disease. For pediatric AVMs, and the MDT model is also very useful to treat pediatric AVMs. Okay, this is my reference I checked for this presentation. Thank you very much.
Thank you very much. It has been a wonderful presentation. You elaborated the entire history and treatment outcomes of AVM. Thank you very much. We can take questions. My co-host, Dr. Liu Sen, any comments from your side?
Thanks, Raja. Thanks, Professor, for a nice presentation. I wish to ask from you regarding pediatric AVM. Are they simply considered a congenital lesion? Because this is often a question asked by the insurance company. Second thing is a patient who underwent embolization treatment. Is there any advances to tackle the angiogenesis post-embolization? My last question, Professor, is incidental venous aneurysm reason for treatment in pediatric AVM? Thank you, Professor.
Okay, let me answer the second question first, because the embolization of the AVM is very common in our AVM treatment, not only in pediatric cases, but also for adult cases. For some adult cases, we can embolize some very large AVM, not maybe 1 time and 2 times and 3 times, and last maybe we can totally embolize the AVM. But for these cases, some a larger amount of the cases will recurrent. So we should follow up them for a very long time. If the AVM from a very high grade AVM after embolization, maybe it will grow to maybe reduced grade. But also sometimes it may be a very side effect that if you embolize the feeding artery, that's very easy to coagulate during the surgery. If at that time, I think the embolization has side effect, because the AVM nidus will change. When the blood supply is easy to cut, at that time you embolize these kind of arteries, some other arteries will open. At that time, the nidus changed. So embolization should be considered for the part of the strategy. After embolization, we should reset the AVM nidus as soon as possible, because maybe you followed up embolization a long time. At that time, the nidus will change. So at that time, you have to re-evaluate the nidus, to re-evaluate the strategy. That's my opinion. I'm sorry, how about the first question? I'm not clear, get your first question.
My first question is, in your practice, is a pediatric AVM considered a congenital lesion? Congenital? Or because some adult cases, they have proven that it's not congenital?
Yes. Just now in my presentation, there are 2 kinds of conditions we should learn from that. Because the congenital situation, I met very young patient, only 1 year old. He suffered from very severe hemorrhage because of the AVM. At that time, it is very difficult to discuss. And I also follow up 1 patient. Now she is 28-year-old. He was diagnosed brain AVM 14 years ago. At that time, she is only 14-year-old girl. At that time, it is a very large AVM. It is very difficult to treat. It has a very high risk to treat. At that time, we discussed with the relatives and also her parents to just follow up. 14 years later, we still follow up. She is now 28-year-old. She had delivered 2 babies, and then she married and delivered 2 babies and also had a very good work. This time, the AVM is still very stable. So we discussed with the patient. We tell her that maybe it is a congenital one. When you are born, you are born with AVM. So it is one part of your body. So you just keep your blood pressure normal. You just follow up, because it's a very large one, very diffuse one. It is very difficult to treat. So the patient had no symptom. We can just follow up. And also for very young infant, when maybe he is only 1 year old, very young, we can just follow up if he had no symptom. It's my opinion for this kind of disease.
Thank you. Thank you very much, Professor. It was indeed very interesting to know that a patient with AVM delivered 2 babies without any intervention and complications. Really surprising. One thing I would like to know about, how is your long-term follow-up in pediatric patients? Because one of the largest series from Salt Lake, Utah, which came out in 2019, which was a multi-center study, and they had around 92% of the 97 patients had a good outcome, like MRS of less than 2 on long-term follow-up. What is your data on long-term follow-up of these patients? Because as you said, these are very aggressive AVMs, but also children have a very good plasticity. So they have less functional disability as and when they grow up. What is your feeling about this?
Yes, I think not only for the AVM, this kind of disease, but also for some tumors in the brain. We should not only focus on the disease itself, but also we should focus on the brain functional around the disease. For example, sometimes some benign tumor, such as meningioma, it is located in the eloquent area. It is not so large. And also it is very close to the eloquent area, just like the AVM, very close to the eloquent area. If the patient had no symptom, I think we can just follow up. When the tumor enlarged, when the AVM changed, we have, the patient has more time to let the brain have the reorganization, because the eloquent area will go away. Maybe go to some rejoining some other places, maybe to the contralateral area. Maybe the brain has time to reorganization. After that, the lesion is more safe to resect after that. So I think we should actively thinking this kind of situation, because the brain is actively reorganization. So when we treat AVM located in the area, the eloquent area, and also the same situation when the meningioma in the eloquent area, if the patient had no symptom, we can just follow up. We give the patient the time to have the brain reorganization. I think it's my opinion. And also some, for example, the meningioma very close to the veins. For example, the parasagittal meningioma. The sagittal sinus is normal. When we resect the tumor, maybe we will affect the sagittal sinus. But if the patient had no symptom, we can just wait. When the tumor enlarged, the sagittal sinus may be occluded. At that time, you resect the tumor will be more safe, and the patient will have very good outcome after the tumor resection. And I think that also it is true for the AVM resection.
Thank you. Thank you very much. We can invite comments from Professor Hodai as well. Professor Hodai.
Thank you so much for your presentation. I really enjoyed it. Even though I'm not a vascular surgeon, I learned quite a lot. Thank you. Perhaps you could comment on the fact that your city and your institution, sorry, my video is frozen, but I hope you can hear me. Your city and your institution are quite large, and perhaps you can tell us how many patients per year do you see in clinic, and how many of these patients require surgery? I trust that you have very, very high volumes.
Yes. In our department nowadays, more and more vascular patients come to our clinic room. Just now, in my very beginning of my presentation, said that in China there is these two situations. One is this pediatric neurosurgery patients will go to the comprehensive hospital for just like us. In our Huashan hospital is a comprehensive hospital, and we have a very large department of the neurosurgery, and also we have a special team for pediatric neurosurgeons. And the other situation is that in Shanghai, we have a special children's hospital. They have different departments. One is the neurosurgery department, and then they have vascular neurosurgeons. That is two different. But for the patient population previously, they usually will send the patients to the children's hospital, because the children's hospital, they have more critical care unit for this kind of cases. But now in our department, we have more and more cases for the pediatric neurosurgeons, because our department has more and more NICU doctors special for pediatric patients. So, you know, in the last 3 months, I operated about 4 pediatric AVM patients. And some other patients I sent to the radiosurgery. They have 3 cases in the last 6 months. So, you know, also the children's hospital, they also have many this kind of AVM children's. Yes.
Thank you very much. I think with that, we can wind this up officially. On behalf of the Education Committee of the ACNS and the President, Professor Yoko Kato, I would like to sincerely thank both the speakers of today, Professor Girish Nair and Professor Q Tianmeng, and the Chair, Professor Morgan Hodai, for her time and support for the educational activities of the ACNS. A special thanks to Professor Shubin, who is our main mentor in China and who has broadcasted this webinar across WeChat platform, and we are live on Zoom and YouTube as well. Today, there are around 900 participants who have joined us live for this webinar. Really thank Professor Shubin. A special thanks to my co-host, Dr. Liu Bun Singh, for joining in today. So until we all meet on next Wednesday, it is bye-bye from everybody. Thank you very much for joining.